Hi, everyone. Welcome to Quality. This is your host, Arjun Venkatesh, where we're exploring quality in emergency care. This is the next episode in our series from our Emergency Quality Network Equal Stroke Initiative. And I'm joined by my partner in crime, Dr. Corey Zackerson from Mass General Hospital as an emergency physician and stroke researcher. And our special guest today is Dr. Bernard Chang, who's an emergency physician and vice chair of research at Columbia. He's done a ton of interesting work out there, but today we're going to be focused in on really continuing our discussion about TIA. And when we're talking about TIA, it's about one of the hardest decisions that we make as emergency physicians, which is whether to admit the patient, discharge the patient, observe the patient, what is safe, what can we do, what's the current science telling us. And so, Bernard, I'm going to kick it off with just letting you have a chance to tell us about a study you did that got a lot of press a couple of years ago, right before COVID, called the RAVEN study, where you guys really tried to do something innovative to help get patients with TIAs home. Tell us about it.
Yeah, sure. Thanks so much, Arjun and Corey, for having me join today. With regards to the Raven study, a lot of it was driven by some of our observations that we saw in our emergency department with our treatment of both TIA and minor stroke. Folks who are staying in the emergency department for quite a while, being admitted, and oftentimes having quite prolonged workups in the emergency department and in the inpatient setting. Some of the research that was going on outside of the US, in particular in the United Kingdom and France, some trials looked at what would say a rapid turnaround treatment in the emergency department, where they would do an initial work of a diagnostic evaluation, and then from there discharge them to follow-up, where they would be seen by stroke neurologists or some specialists in a rapid turnaround versus watching them in the hospital. Some of the data initially from those studies were quite encouraging. So talking to our team here in New York, we said, well, what could possibly be applied from some of those studies in our setting in the emergency department? And in particular, for us, the two challenges in particular were from a safety standpoint, and then also from a practical standpoint, because as you know, in the emergency department, we serve such a diverse range of patients, and we want to be able to make sure that oftentimes we are a safety net for patients. And if we're discharging individuals, we wanted to make sure that they would not be falling through the proverbial cracks. And so that was really the initial spark that kind of led to the development and collaboration with our colleagues here in neurology for the Raven Clinic.
That's great. Thanks. In looking through your results, it looks like you really did show that you could do it safely and you could do it well, and you were able to, follow up with the majority of patients. Do you mind just speaking a little bit more about your safety outcomes? I know not all patients made it in for follow-up, but it looked like you did sort of hear from everybody and had good data on outcomes. Could you share some of that with our listeners?
Yeah, sure, Corey. So in designing the Raven protocol, we really wanted to make sure, thinking about it from an evidence-based standpoint, but then also from a social implementation standpoint in the emergency department, recognizing a lot of those challenging follow-up issues that we see oftentimes in the emergency department. So we really tried to coordinate with our neurology colleagues in making sure that on discharge, all those individuals who are screened in for Raven, all those individuals with TIA or NIH stroke scale of 5 or less, or non-disabling stroke, some of those safety features were addressed. Then we wanted to make sure that those individuals then had kind of good follow-up. So we tried to make sure the follow-up was established during the ED visit. We kind of ensured kind of a transportation standpoint. So we actually coordinated with some of our care coordinators or social workers to make sure that was also in place. And then lastly, we had a two-step process for following up those individuals, both kind of having the contact information as well as reaching out to them if they were to show up, or having some flexibility within scheduling, so that ultimately we want to make sure that the onus for those individuals who we discharge into the proverbial outpatient ether had a means and closed loop communication for the team, for the stroke outpatient team, to ultimately see with them. So we were able to, with our initial follow-up rates, we're quite successful. And so since then, we have had continued success with this. Of course, in the setting of the pandemic, it's made things a little bit complicated. So we've had to tweak our protocol a bit, but we have had similar outcomes, kind of upwards of almost around 92% of individuals in Raven, discharged to Raven, still following up within that 48-hour period.
You know, Bernard, that's really interesting when you describe sort of the additional measures you put in place in the emergency department setting for these patients? Because I think a lot of TIA protocols are either tough to generalize, or a lot of just ED quality improvement interventions are tough to generalize because people often will put exclusions in around these social determinants of health. So anybody that has challenge in transport, or anybody that's got challenge in, being able to do telephone follow-up, or anybody that's got challenges around their housing security, financial security, you name it, get excluded often from these interventions. It sounds like what you're saying is a little bit different, though. It sounds like you guys said, we'll include them, but we'll try to do some other things so that we can be inclusive of a broader population.
Yeah, that's correct, Arjun. And I think that we tried it. So we took an iterative process to this. The beginning, we wanted to be a little bit more strict with some of the exclusion criteria, in the sense that we didn't know, A, this is safe, A, this is even feasible. And so with the initial tranche of individuals who were met the inclusion for Raven, we were a little bit pickier in terms of, well, from insurance standpoints and from a follow-up standpoints. But then as we saw that, okay, it seems that discharging some TIA and minor stroke patients seem to be safe and seem to be feasible. And then we're like, okay, we need to be a little bit more inclusive of the reality of the fact that many of our patients coming in with TIAs or minor strokes have different social determinants of health that might make the practical implementation of such a strict criteria not really feasible or practical for many of ourselves here in our department, as well as kind of more of a generalizability standpoint. So we've kind of worked in coordination with our social work, our care coordination teams, to really try to make this a more practical, externally valid protocol. And I found personally the most interesting thing in some ways, when we started this protocol, I was most worried about things along the safety standpoint, from vessel imaging, kind of along the lines of some of our other guests on this podcast, with regards to like the evolution of tissue-based diagnosis and the need for imaging, and some along those like more what I call pathophysiological diagnostic challenges. But what's been probably the biggest challenge with the Raven Clinic has been when we say, okay, based on these pathophysiologic criteria, they're okay for discharge and for this 48-hour follow-up, but now how to actually make sure this individual shows up at the clinic. And so that's been one of the biggest challenges for us in terms of coordinating with some of the other services that interface with the emergency department to make this really what I would say a practical and implementable kind of tool in our kit with treating stroke in the emergency department.
I got to think that as I'm hearing this, it's important sort of what you're saying, which is it's about sort of your ability to collaborate with other services. It's your ability to sort of do the blocking and tackling on the ground for sort of basic patient navigation and get into services. But I'm best betting that we've got listeners who are probably also thinking, well, that's Columbia. That's Ivory Tower, Ivy League. It's challenging, sure, in New York City and an urban environment, a variety of other things, but you probably have resources we don't have. If you really had to push yourself to think about what were the critical resources necessary to have this, are those things that many of the community rural EDs that are part of Equal could sort of muster?
It's a great question, Arjun. And I think that when we had thought about Raven years ago, our aspiration actually was one day to be able to think about, can we, as emergency physicians, think about managing TIA or minor stroke in a way that collaborates with our specialist colleagues like neurology, stroke neurology, vascular neurologists, but may not be necessary for them to be interfacing with us for certain protocols. And so with Raven, as you saw in the initial phases, we made sure that we interface with a stroke neurologist. And part of it in some ways was, you are right, we are living, at least with the study, in a bit of a proverbial ivory tower, in the sense that we have 24 stroke neurology available, we have MRI imaging, we have a lot of these resources that from a practical standpoint may not be available in many other clinical settings. But we wanted to take advantage of those resources in the initial phases of starting the study to kind of validate it as safe and feasible. But in sense, what I would say, like the evolution since Raven was first started and published on, we've started gradually transitioning to this phase of what can we in the emergency department do safe and feasible without interfacing with neurology. That we want to, of course, be in touch with them and collaborate with them, but are there aspects of this protocol that may not need a neurologist? So what I mean by that is, since the protocol started, for example, during COVID, we had, of course, lots of extreme limitations in resources, evolutions in terms of telehealth and kind of the deployment of telehealth technology. And so we had initially had in-person neurology evaluations for some of our stroke evaluations, and we had to transition to telestroke for some of the TIA and minor stroke evaluations in our satellite campus within our university. And based on some of the initial data from there, we saw similar safety feasibility data. We're now proposing to look at a pilot now where this protocol is kind of internalized within the emergency department without an inpatient neurology consult, and then seeing the outcomes from there. And so that's ongoing. So I don't have any of the data from that right now, but I'll at least say, like, about 2 weeks ago, when we were initially going to try to do this podcast and then had to reschedule, I've since kind of took a first peek at some of that feasibility data, and we are seeing a little bit of similar trends that we have with our existing larger Raven data set. So what I would say to that, Arjun, is that there seems to be a lot of the resources potentially that we can be doing it in-house without what I say the quaternary or super specialized resources that are available at some of these larger academic medical centers. So it's, what I would say is, there are, of course, certain resources that are available at, say, a comprehensive stroke center, but there are still many protocols, hopefully, that will be available to all of our providers, irrespective of practice setting.
Yeah, this is great. I think, your data are really compelling. And I think the idea of being able to discharge more TIAs and minor strokes from the emergency department is probably, really appealing to so many emergency physicians who are listening. And so I wonder if we could just do a little bit of a thought experiment and put ourselves in the place of, like, an ED director at a community hospital who's trying to make the case to their site that this would be a great thing to work on implementing. Can you share some of your cost effectiveness or bed days saved data? Like, what are some of the numbers that they could bring back to their hospitals to say, listen, this would really benefit the entire system if we were to implement something like this?
No, it's a great question, Corey. So we've started looking at some of the health economic data, some of the outcome data from Raven with our first tranche of initial data. And so the caveat is that with the initial tranche of Raven, it was a little bit more exclusive in terms of kind of like the criteria. And really, we really wanted to make sure that folks were really following up. So folks were really kind of plugged in with, we had a social worker, and we had kind of things that I think now, as we've expanded Raven, some of those resources are not as readily available. But we did see from a 30-day rehospitalization standpoint, those individuals compared to kind of match controls, individuals who were along the traditional route of being brought inpatient for their TIA or minor stroke, they had approximately about a 20% reduction in their 30-day rehospitalization compared to individuals who had similar TIA minor strokes but were admitted. So yeah, a 20% reduction in your 30-day rehospitalization. And then from the standpoint of an all-cost dollar utilization for those individuals, we also had essentially about an $1,800 reduction in their cost per hospitalization for individuals in a Raven clinic. And I think most of the bulk, if you looked at the 18, where those dollars saved were from the healthcare utilization standpoint, the proportion of those was saved from the hospitalization costs, kind of the costs associated with hospitalization and kind of like prolonged length of stay. So I think some of those data were encouraging for our operations team from that standpoint. And I think one of the things that we've also been very curious about is interface with other emerging technologies within the healthcare system, in particular like telehealth. And so we've had now with Raven, it's a bit of a hybrid mix for patients that both with in-person evaluations as well as tele-remote evaluations. And what we have seen is an increase in adoption for those individuals who, if you look at kind of the historic demographic of some of those individuals, older adults who has made some a little more from a technological adoption standpoint, is not as been high, at least within our population that we're serving. And we do see kind of an increased adoption from that standpoint too. So I think there's all this, but I say some of the what I would say the positive direct effects for utilization of a protocol like this, but then there's also some indirect benefits too as well, both with the patient engagement and adoption too as well.
I want to dig into that patient engagement one a little bit more, because I can imagine from a patient's perspective, they're coming to the ED because they're afraid they're having a stroke. And that for most people can be one of the most, terrifying days of their lives. They've come to the emergency department. They're probably feeling a little bit better about the fact that they're getting better or their symptoms are milder. But I would imagine there's a handful of patients that probably thought that they are going to get hospitalized and that this gets worked up and that there may be even all kinds of treatments and things done in a hospital setting. And so how does that experience tend to go with patients when you're talking to them and they it's a little bit of a reverse from maybe what some of them were expecting, to hear that they could actually go home and that they're going to be all right, and that there's a follow-up and that this doesn't have to be done in the hospital?
So we're very interested in the patient experience, the psychological outcomes in patients with TIA or minor strokes. Actually, one of our studies that we've been looking at has been looking at the rates of what we call post-traumatic stress, or PTSD, among individuals with stroke. So it's quite surprising, but most of us, when we think about PTSD, we think about it with war trauma, sexual trauma, but there has been a lot of literature talking about individuals who suffer from stroke or heart attacks or myocardial infarctions have rates of PTSD upwards of 20% in individuals. And this impacts not just psychological outcomes, but also health outcomes. Many of these individuals with PTSD go on to have increased 1 year overall morbidity and mortality compared to individuals who survive a stroke or ACS event, acute coronary syndrome event, without PTSD. And one of the things that we've been very interested in with the Raven Clinic was some of the factors that seem to drive the PTSD risk for some of these individuals have been prolonged hospitalization and exposure to what I would say some of the occupational stressors that we in our profession are exposed to, with crowding, noise, sleep dysrhythm, circadian cycle that you're seeing, that you're sleeping terribly in the hospital, you're eating terrible food, you're not mobile. And so a lot of these risks of the whole hospitalization experience in turn accelerate some of the stress that many of these individuals surviving acute medical event, such as a stroke, experience. And so with some of these patients, we do have a minority of patients, to Arjun, your point, where they say, hey, I came here with this potential life-threatening event. Why am I not being admitted to the hospital? What's going on? But it's been interesting seeing from the qualitative data that we have that many of them seem to be reassured that when the providers are saying, hey, good news, we've done this evaluation, and it is concerning that you seem to have this medical event called TIA, or a minor stroke, but the good news is it doesn't seem that we need to do anything immediately right now for that, and we have a good action plan, safety plan for you to follow up in a short-term time frame for that. And many of the patients, I think we've been pleasantly surprised by the positive feedback we've had from the patients about this, because we do follow up with many of our Raven patients about kind of their experience from this. And are you happy with being discharged? Do you prefer to be admitted? And we see mostly about 77% of individuals who are discharged to Raven Clinic do prefer to be discharged rather than be admitted. And we have been following up PTSD rates for this sample of individuals in Raven, part of our larger study of PTSD and stroke that we've been doing here at Columbia. And we've seen that actually their rates of PTSD compared to individuals with similar stroke severity scores is a bit lower. I would say it's about 11-12% compared to 17-18% that we see on the whole with our sample. And so it's hard to say that the Raven Clinic itself is driving this difference per se, or maybe there's a difference in the type of individuals who are being discharged. But I think at least it's reassuring from the standpoint that with that difference, and also with the qualitative feedback that we're getting from our patients who are discharged to Raven Clinic, that it seems that patients seem to be okay with that decision to kind of discharge them versus admit them. And we're actually potentially even seeing some positive benefits from not having that long exposure to the hospital.
That's really interesting. And particularly, thank you for sharing that additional research. I think often we get really focused in emergency medicine on this narrow question of, is this person going to have a stroke in the next 48 hours? It's a very kind of clinical risk-averse type of outcome, but it's one of many, many different outcomes. And you guys have certainly been thinking about that safety outcome, but you're thinking about a person's whole health, their mental health, and things like that over the course of acute illness. And when we take that lens to it, I really think that one of the things I really appreciate and take away from today's discussion is that setting up these models of care to discharge patients with TIA is aligned with many patients' preferences. It may be better for their health to be able to avoid hospitalization and better for their mental health. It is certainly more efficient and better in terms of our use of scarce hospital resources, particularly at a time when we've got fewer and fewer inpatient beds available. We've got unprecedented levels of crowding and boarding in our EDs. And I think probably the most important thing at the end of all this is that we can really do this safely, and we should really think about care a lot differently than maybe what we were taught in residency. So thank you for joining. Thank you for making us all a bunch smarter, and we hope to have you back on a future Equal podcast.
No, thanks, Archie and Corey. Really a pleasure. And just a quick shout out to all the listeners too, as well, if that anyone interested in collaborating over this too, as well. We really love to kind of hear from you. We want to hear from a group of diverse folks outside of the ivory tower too, as well. I think we want to make something like this really workable for all of our listeners and all emergency physicians out there. So thanks again.